Okay, hi Leah, my name is Megan Larkin and I'll be the nurse practitioner examining you today. I'm just going to start by washing my hands and then we're going to do a full respiratory assessment today.
Okay.
Great. So first thing I would note Liam's general appearance and do some vitals and make sure those are all within normal limits. So he's not in any obvious distress and his vitals are all within normal limits. So I move on to a respiratory general assessment. So I'm looking at the rate, rhythm, and depth of his breathing. And I would know from the vitals what his actual rate was. So 12 to 20 would be within normal range. I don't hear any audible wheezes or stridor or anything concerning like that. I can assess for tracheal deviation. So Liam, I'm just going to touch your neck here. So I feel on both sides of the trachea, and the distance between the trachea and the sternocleidomastoid muscle is the same bilaterally. Would you mind taking your shirt off for me, Liam?
No.
So, and then I can proceed with the rest of kind of the respiratory general assessment. So, thank you. So I'm just going to observe his breathing, looking for any increased work of breathing. So I don't see any accessory muscle use. I don't see any retractions in the intercostal spaces. Everything looks good that way. So yeah, I'm gonna move on to inspection and palpation. I'm gonna kind of go from anterior to posterior. Liam's a young man, so he can kind of move for me in the chair if I need him to. So inspecting the anterior chest, I'm looking for symmetry, any obvious deformities. I'm just gonna palpate. Liam, you just tell me if you have any pain.
No pain.
Awesome. So continuing inspection, I can compare the anterior posterior to the lateral diameter. So I'm just gonna get you to kind of move your arm to the side for a second. So the anterior posterior to lateral, the AP, yes, to lateral chest diameter should be 2 to 1, which his is. So we just want to make sure he doesn't have a barrel chest or anything like someone with COPD would. Great. So if you can kind of sit sideways in your chair, I'm now going to inspect and palpate the posterior chest. Again, looking for any obvious deformities, symmetry. Everything looks, can you just kind of cross your arms and just kind of keep taking some nice relaxed breaths in and out. Let me know if you have any pain when I'm palpating. Any pain?
No pain.
Okay, great. So I don't feel any deformities there, so I'm going to check for symmetrical chest expansion. So around the costal margin, I'm just going to get Liam take a nice deep breath. Good. So my thumbs move the same distance on either side. If there was bilateral restriction, you would be thinking some type of restrictive lung disease, where if it was unilateral, maybe a lobar pneumonia or pleural effusion or something. But his was symmetric, so that is great. We could also do tactile fremitus, which would be more likely to do if he'd had some type of respiratory complaint, but we will do it now to demonstrate. So I'm just going to use the ulnar side of my hand, and Liam, when I touch your back, if you can just say 99.
99, 99, 99, 99, 99.
Perfect. So I'm feeling the vibrations through my hands to making sure they're the same on both sides and all the way down, which they are. Perfect. So now I'm going to move on to percussion. So we're going to start posterior, going to go kind of a ladder-like pattern down the back, and we're listening for resonance, and that there's no change in the kind of tone. I'm going to avoid the ribs, so I'm going to go in the intercostal spaces and use my middle finger and tap with the fingers of the opposite hand. Making sure we kind of get lateral as well. Great. I could percuss here for diaphragmatic excursion as well if I wanted to test that. So I would get Liam to take a deep breath out and hold it, percuss from resonance to dullness, and then take a deep breath in and do the same thing. So a normal finding would be like 3 to 5 centimeters. I'm not going to do that right now because I'm not really concerned about Liam's lung volumes. So if you could, Liam, turn again to the front, and now I can percuss anteriorly. Perfect. So resonance all the way down. So now I'm going to move to auscultation. So I'm going to use the same ladder-like pattern and auscultate throughout all lung fields, listening for the pitch, intensity, and duration of inspiration and expiration. Looking for any adventitious sounds such as crackles or wheezes. Yeah. So if you can just take, Liam, nice deep breaths in and out through an open mouth. Awesome. Now I'm just going to auscultate posteriorly. If you can turn to the side again. Good. Going to go through all the lung fields again. Nice deep breaths through an open mouth. And if Liam had a cough, or if I did notice crackles or something, I could get him to cough, and I could auscultate again to make sure that was not the cause of the adventitious sounds. But that's not the case today, so I don't need to do that. Another couple tests I could do if I was concerned about his respiratory system at all, or if he had a respiratory complaint. One of them is bronchophony, so I could auscultate again through all the lung fields and get him to say 99 or Scooby-Doo, and if there was like a change in how that sounded kind of as I was auscultating, that could indicate consolidation. Egophony, same thing with auscultation, get him to say E and hold it, and if it sounded like A to me, could indicate consolidation. And then finally, whispered pectoriliquy, get him to whisper 99, and if it sounded louder in a certain lung field, that would also be not a normal finding. So those are some more tests I could do if I was concerned. All right, Liam, I think that concludes our respiratory exam.
Awesome. Thank you.